So that's a picture of the institute where I work at this point in time. Of course, I spent 25 lovely years in SGPGI and my heart is still there. I thought I'll take a slightly what is known as a ringside view, that is looking at it a little bit from a distance. So what you have asked me to talk about is the role of gut microbiota in fatty liver disease, probably obesity and fatty liver disease, and NODAT. So the first question that comes to my mind as a skeptic is that before we dive into the details of all the pathways, is there substantive evidence that there is a role? And if so, how convincing it is? So from that point of view, I think the most convincing thing that I read in the last few years was this experiment, which, if I remember right, was done somewhere in Israel, where they took the gut microbes from obese rats and then they put it into lean rats. And then they found the ones who got the microbes from the obese rats became obese. Now that, to my mind, was extremely convincing, that here you are passing on a trait which seemed to have come from the gut microbe.
Excuse me, would you please unmute yourself, because Dr. Choudhuri is speaking right now.
Thank you. No problem. So to my mind, that was the single most strong piece of evidence to suggest that the gut microbe, and that was the only factor taken from obese rats and put into those lean rats, they seem to have converted a phenotypic expression only through the gut microbes. Then I developed a little more interest and I thought that, okay, fine, this argument seems a little convincing and let's move forward. Much of this has been discussed by Dr. Vikas and thereafter by the other two speakers. And we all seem to know how it all goes from early childhood to adult onset to late onset and so on and so forth. But what one really needs to understand is that as we grow older, the gut microbiome seems to be much more easy to be manipulated by food and lifestyle and so on and so forth, and the use of antibiotics. And so there are a lot of variables which seem to come. Prior to that, the way we are born and the way we are growing up, there doesn't seem to be too much of a choice in us, except of course, if it's vaginal delivery and, if the child has been breastfed or not. But, those are actually things which are fairly well established. And I won't talk about it because I'll come to the latter part of life. Now, the development origins of obesity, looking at it, so these are the factors: breastfeeding, formula feeding, early complementary feeding, and so on and so forth. So the route of delivery and the feeding mechanism in the early part seems to have an important role. And suffice to say that what they determine is the gut flora of infancy and thereafter childhood. And probably some of this microbial signature lingers on, and that's what determines what we come up as a phenotype. Of course, there are genes, you can't discount that. You know that, genetics is a very important factor for obesity and fatty liver disease. But these are the other variable factors which needs to be kept in mind. And if you could see this slide, I think Vikas talked a good bit about the usual ratio between Firmicutes and Bacterioides. And I think Dr. Prasad also alluded to that. So when we don't understand too much, we look at ratios, and it's a fact that Firmicutes are the ones which are gram positives, usually associated with a lot of carbs and fats in the diet. They in turn seem to cause more obesity and fatty liver disease. Bacterioides are the ones which are the dainty gram-negative bacteria, more gram-negatives actually. They seem to come when we eat a lot of legumes, fruits, and green vegetables, and they seem to keep the Firmicutes in check. So that's the way I understood it in a very simplistic term. And this is a complicated slide to only tell you that one of the major ways in which you can modulate your gut microbiome or microbiota is through what you eat. So everything else is secondary. Of course, use of antibiotics and all, which Dr. Amit alluded to, are also important, but primarily what we eat. I'll come straight to the topic of gut microbiome and NAFLD. I alluded to obesity in rats. Now we come to non-alcoholic fatty liver disease in humans. So it's a complicated relationship. So let's assume that obesity and NAFLD are also related. And then within NAFLD, there is, of course, quite a few types. So NAFLD is, by the way, extremely common. Even when I was in Lucknow, I remember we did these urban studies. I think Ish Bhatia did one. And it was found that about 40% of urban citizens in Lucknow had probably fatty liver disease, diabetes, or hypertension, one of the factors for metabolic syndrome. It's common in India, and the range is mentioned here. And now recent evidence suggests that apart from lifestyle, which of course even WHO feels is the primary cause, there is growing data that the gut microbiota could also be responsible. The question that begs a good answer is that when we observe a change between people with fatty liver disease who are obese and those who are lean without fatty liver disease, is it an epiphenomena or is it causative? And that's $1 million question. And one has to, it's the usual egg and chicken story. And that is not always very easy to answer when you have very large amounts of information or data rolling out. Changes in the gut microbiome in patients with fatty liver disease, particularly, they're mentioned here. The Bacterioides tend to come down, the Fermi go up. I mentioned it in a passing. Every time I actually review this literature, few new names come up. So the new one here is Prevotella. Okay, and then there was another one, of course, Bifidobacterium is not so new, but there were quite a few others which I'll allude to. So what actually happens to the various types? Amit mentioned that apart from Firmicutes, these bacteroids, there are apparently 7,000 types of them. So it's impossible for me, who's not a microbiologist, to actually even make an attempt to remember 50. But 7,000 is a rather large number. And then you have to really play around with names and proportions. This was a recent paper on the characterization of gut microbiome in non-alcoholic steatohepatitis patients, a connection between endogenous alcohol and NASH. A good paper. And for those who may not be too familiar, of all types of non-alcoholic fatty liver disease, there are two types. One is called the bland NAFLD, the non-alcoholic fatty liver disease, which doesn't have too much of inflammation, doesn't seem to progress to fibrosis and cirrhosis. On the other hand, this variety NASH. So when we did our papers in SGPGI at that time, in the 90s and early 2000s, everything was NASH, but now there is a distinction. So NASH now refers to only the progressive type in which there is inflammation and fibrosis. So even within this fatty liver disease now, there has to be a splitting to see which one is being caused by microbiomes, if at all. And here are a few pictures of different types of enterotypes, 1, 2, 3, 4, Bacterioides, Prevotella, Bacterioides and Prevotella, and so on and so forth. And suffice to say that there has been some degree of statistical difference that has been seen in people who seem to have, if I could move this a bit, the normal, obese, and beyond that is the NASH. So there one could find that there is a particular type which seems to stand out. In science, the depiction of data is very important. So very beautiful colored graphs to show how it differs from different groups. So normal, obese, and NASH. And you see that the patterns are indeed different. And suffice to say that that would be the area for pursuing new research into that area. But the next slide would be very important. Is gut microbiota enriched in alcohol-producing bacteria like E. coli, supplying a constant source of reactive oxygen species to the liver, thus causing liver inflammation? So if I might remind many of you, of course, most of you are probably not of my vintage, but in the 80s, when non-alcoholic fatty liver disease was actually discovered by Hans Popper in the US, it was a group of women who vouched that they hadn't taken alcohol, but the liver biopsy was unmistakably similar to those of people who consumed large amounts of alcohol. And that's the reason why Hans Popper had to get his hepatologist to separately question these ladies that would they mind telling the truth, because it was indistinguishable from alcoholic hepatitis, and they swore that they didn't, and that is how the entity got established, and that was way back in 84. After that, there was a plethora of papers which showed that, well, actually alcohol could be the cause, except that here you're not drinking alcohol, I mean, as for dinner or in the evening, but it's alcohol being produced in the intestine and it is reaching the liver through the portal venous system. Now, this theory kind of went into the back burner for a while, and now it seems to be coming back once again that there could be endogenous production of alcohol by certain types of gut microbes, which could be giving the picture very similar to the alcoholic hepatitis picture of earlier times. Now, the NASH microbiome is distinct from normal and obese microbiomes, and this is how it differs. So people with NASH, you see the bifidobacterium, there seems to be a difference. It is decreased. The Prevotella is increased. We just have been chanting this name a couple of times in the last few slides. And Escherichia, I mean the good old Escherichia, which we have known for so long. Apparently, there is a subtype which is pretty notorious for producing alcohol and has been associated with NASH. Now, it's not to say that the presence of Escherichia itself means that there is bound to be NASH and alcohol. I guess it all depends on the subtype, the subspecies, the subtype, and the proportion. Now, Escherichia is abundant in NASH microbiome compared to the obese, and the fact that Escherichia are ethanol producers may provide a mechanism. Now, this is one of the mechanisms. One of my predecessors just talked a little bit about dysbiosis. I think it was Vikas. So, in fact, while I was listening to my predecessors, I deleted about 10 of my slides because it would be a repetition. But gut microbiota is now being linked to a wide variety of conditions. I think all of them have talked about a few of them according to their specialities and their fields. For example, Amit talked a bit about diarrhea and so on and so forth. But these are the diseases which are under the scanner. And Anita has asked me to talk primarily about NASH and NODAT. But just to tell you that there are perturbations in the microbial flora in a wide variety of conditions. Remember, depression is another one which is gaining a lot of momentum, that maybe there will come a time when you can take a pill of microbes and your depression might actually blow away. So dysbiosis and NAFLD, how exactly does it work? Obviously, it's a complex biological system, cannot be a single mechanism. So there will be a whole lot of things going on. The inflammatory mechanisms, the permeability of the membranes and so on and so forth, the increased production of alcohol, the deposition of fat, and then of course the stimulation of inflammation and fibrosis. We come back to studies, the type which are done in good academic centers like SGPGI, where you actually try to find out colony counts of suspected or culprit germs in different disease states and compare it with controls. And this is what you find. You see, in people with NASH, the Bacterioides relative count is quite high, a particular type. And the ones without NASH had a different count altogether. And particularly, they were looking at Prevotella as a suspect in this case. And here, this is another very interesting slide. The red ones are basically, the red bars indicate fibrosis. And if you remember what I mentioned about NASH, NASH is that inflammatory variety or the inflamed variety which leads on to fibrosis, is more often associated with many of the risk factors, early deaths, cardiovascular disease, and so on and so forth. And the other name that seems to be coming up every now and then is this ruminococcus. Ruminococcus, by its very name, these cocci, gram positives, they're usually in the category of Firmicutes. And I told you these Firmicutes are the ones which seem to have an affinity for fats and starch. And it's been shown that it's associated more often with the development of NASH rather than the bland fatty liver disease. Okay. So some more evidence coming our way. And this is another one where people are looking at intestinal permeability. And we all know that, intestinal permeability is important for causation of a wide variety of diseases. Vikas was the opening batsman. So I think one of the methods or mechanisms of inflammation being stimulated is through a leaky gut, what we used to call as a leaky gut syndrome. And now the leaky gut has been propounded as a theory for a wide variety of conditions, including NASH. And that seems to be holding now, that there seems to be a leaky gut in many of these patients. Ruminococcus, Prevotella, two organisms to keep in mind. I will just wind up by summarizing that it is not a very simple thing like, the COVID RNA2 virus causing COVID, just one single etiologic agent for a disease. Here it's actually a little bit more complex. And therefore, the fatty liver and NASH seems to be caused by a combination of a variety of these factors. So there's gut permeability is under the scanner, lipopolysaccharides, how they are actually reaching the liver, the inflammatory factors, I think again, Vikas referred quite a bit to that. Endogenous ethanol, I just mentioned about Escherichia coli and several other bugs which seem to be producing alcohol in the small intestine. The short chain fatty acids metabolism, the altered bile acid metabolism, and the increased carboxy extraction mechanisms. So all this seems to be happening due to the gut flora, and therefore what is going from the intestines up to the liver through the portal system, it does affect the liver. And nowadays, I think Amit would bear me out, Dr. Uday and his team are very fond of now saying it's no longer the brain-gut axis, it is the brain-gut microbiota axis. And apparently the microbiota factor seems to be coming in and playing a role in a wide variety of causation of diseases of the gastroenterology, hepatology segment. Probiotics, one of the main problems with probiotics, and I would like to make this comment under caveats, why there is so much of pouring out of data on probiotics and gut microbiota is because of funding by the pharma industry. I mean, obviously somebody has to have a stake. Nobody, for example, does research on lifestyle alterations for GERD management, but you will find a plethora of articles on PPIs in GERD management. So funding makes a difference, and everybody, after all, young people do need to publish papers and get it into good journals as far as possible and study phenomena. But that's what has been said about probiotics. I would appreciate the word of caution placed by, I think, Amit, that this is what we hope to achieve. But how far we are going to achieve, we don't know. Which cocktails are good? Are they good enough? would they be the kind of a panacea for all problems, or are we going to require different types for different specific problems? I think these are big open questions still as of now. The last part of my talk would be on gut microbiota and NODAT. NODAT is new onset diabetes after transplant. To be honest, I don't deal much with transplants. And thereafter, when Anita gave me this topic, I actually looked up what is NODAT. And then I realized, NODAT is actually new onset diabetes. And it seems to be occurring much more frequently than I had realized. I guess Amit and others, who are nephrologists and who deal with a lot of kidney transplants, and Rajan, who deal with liver transplants, would be much more aware. So it's 4 to 25%, pretty high, after transplant. And that seems to be the figure for developing diabetes after solid organ transplants. The variation of 2.5 to 25, almost a tenfold variation, probably is linked to the way you define NODAT. And finally, it comes down to what is NODAT. So NODAT is, you need to have value of 200 milligram per deciliter of glucose, or FPG of more than 126 to RPPG. So this has been standardized. The only point that you need to be careful about is that normally even I in my clinic, do a screening test by getting a HbA1c for the diagnosis of diabetes or pre-diabetes. That doesn't seem to hold for the diagnosis of NODAT. So I think you do need to get fasting blood glucose done. And if you have that positive within a year of having a transplant, so don't be too, I would say, in a haste to diagnose NODAT within, say, a month of a transplant, because that is bound to happen due to many causes. I'll just enumerate. But if it's within a year, a person has developed florid features of diabetes, then of course the label for NODAT seems to fit. So incidence of new onset diabetes mellitus before and after transplant. Now you see, this is what it is before transplant, waitlisted. Obviously, these people, be it whichever organ you talk about, the kidney or the liver, anorexic, emaciated people, vomiting away, poor oral intake, so on and so forth, waiting for their turn. And then comes the opportunity for a transplant. And if everything goes well, they are bouncing back to life. Of course, they need immunosuppression, glucocorticoids, quite a few other immune modulators, and so on and so forth. Suddenly, they start eating much better, and several other things happen. And sure enough, within 1 year, you find 22.5 to 25%. So let's keep it at about 15% that many of them would develop diabetes. These are the mechanisms which have been talked about. So pre-transplant, I gave you that morbid scenario, older age, family history may or may not be there. Many of them are kind of eating very poorly and so on. Post-transplant, quite a few things happen. There is improved appetite. Okay, there is immunosuppression, glucocorticoids. Of course, use of calcineurin inhibitors. Calcineurin inhibitors have been associated with a fairly significant jump in the frequency of NODAT. Positive energy balance, and then of course several other things happening here. So those are the mechanisms. Note that I haven't mentioned gut flora here, because gut flora would be a later entrant to the scene. And the risk factors for NODAT, there are non-modifiable ones, there is a potentially modifiable ones, and the modifiable ones. And it's important to keep in mind that in the modifiable one, the primary one seems to be many of the agents that we use for immunosuppression. But now our focus turns back to gut microbiota, which has been given to me as the topic. So people have studied these people with NODAT and found that the gut microbiota composition does get altered in these patients. And it seems to be a little specific to those who have developed NODAT compared to others who have not developed NODAT. And that is where the scientific question comes, that is it an epiphenomena or is it causative, and which germs and how? And that's, I think, what Anita also wanted brief coverage on. So this is what it shows. You see, if you look at Lactobacillus carriers, you find that controls is around 40, but when you look at NODAT and diabetes, they're actually pretty high, around 80 to 90. Same here, and so on and so forth. So this is only an indicator that, look, after all, something is happening in the gut in patients who are developing diabetes post-transplant. On NODAT, I don't want to speak much because I think, unlike fatty liver disease, NODAT at this point, I would say, is still in a stage of early observation. And we have just started thinking and enumerating who could be the culprits. We really haven't moved too much yet into the realm of therapeutics in NODAT, but I guess it will be a matter of time before we reach there. But it's interesting to realize that gut microbiome could be causing so much things that we had never realized before. To conclude, this is Richard Feynman. He got the Nobel Prize for Physics. And I guess many of you would have read his book, fantastic book. So I would rather have questions that can't be answered than answers that can't be questioned. And I think that at this point in time, we are poised in this whole area of gut microbiota, in an area where there are bound to be questions, and I'll be happy if I'm not able to answer them, which means that is within the realm of future research. Thank you so very much.